I think one of the things that being in a large organization like this is we have a lot of experience in developed markets and emerging markets. Sanofi's always been at it in a big global footprint. And, running Africa, you could see what the learning could be very much from what people have with private insurance and private sector, if you like, care levels, to how do you transfer that into LMICs. The fundamental piece for us for this is education. And back to very basic education of understanding of what diseases are. We've done a lot with faith organisations because there's a lot of faith organisations that are involved in NCDs across the African continent. We've done a lot of trying to transfer knowledge from physicians that are in major centres out to communities. We've looked at working on some of that digitally because a lot of people have smartphones even if they don't have a lot of other things. So we're trying to do that. Policy changes is a really difficult one. But if I go back to my original comment around, we're seeing now more governments are having, particularly the ones we meet in Africa now, are much more waking up and realising that there is an NCD pandemic.
Welcome to Global Diabetes Insights, your go-to podcast for navigating the world of diabetes. I am Tino, a certified diabetes educator and a global advocate for non-communicable diseases.
And I'm Kona, a global advocate and a medical doctor. Together, we're your hosts, dedicated to raising awareness, fostering open discussions, and creating a safe space for everyone affected by diabetes.
Join us as we dive into empowering conversations with individuals living with diabetes, caregivers, healthcare professionals, and researchers. Our goal is to not only guide you through effective diabetes management, but also to inspire advocacy for proper healthcare access.
So get ready for a journey of insights, ideas, and diverse perspectives. Let's amplify our collective voice and create positive change. Get involved, get engaged, and join us in creating the change we need. So welcome everybody to Global Diabetes Insights.
In the very start, we've been interviewing people living with diabetes who are doing so well. I was trying to give you a background. Also, we go to see these other healthcare professionals who are really doing so well, research work, not just clinical work, who are doing research to back up their clinical work so that they can serve as an inspiration to the global diabetes community, not just people living with it, but also parents. I think it has been a long time coming. We've always wanted to get in a room with, especially the big pharma. So thank you so much for making the time. Like you said, that's back-to-back meetings, but thank you for making the time to do this podcast with us. It will mean a lot, not just to us, but even to our listeners, because there are some of the questions that maybe the community just wanted to hear from you. So I hope that we're going to have like a friendly and an honest conversation. So I think maybe if you could kindly introduce yourself, like who you are.
So hi, I'm Jon Fairest. I'm head of Sanofi's Global Health Unit. Sanofi's Global Health Unit was set up into our 4th year now. Our mission is to work in low and middle income countries. So far we've targeted 40 countries, 25 in Africa and the rest mainly in Asia. And we're looking at building healthcare capabilities and training, particularly at community level, so that people can manage NCDs, because we know there's a huge pandemic of NCDs. So we have a big focus on hypertension, but also a big focus on diabetes, which is what we're going to really talk about today. Because we know that this is a significant growing problem, and the starting point for a lot of what would be an improvement in overall healthcare is really supporting capability building with community healthcare workers, people who are remote from the major cities. Doesn't mean we don't do work in the major cities, because we do. We also wanted to make a series of medicines available. So we have an impact brand, which is a selection of 30 NCD medicines. We have insurance in there as well, that we wanted to make these available at a non-for-profit rate, but also to make them available in these countries with, after the training, really, in a sense, to make sure that once people have capabilities to understand how to manage diseases, if they choose, they can get to products like ours, and hopefully other companies' products as well. That's what this is about. So that's what we do. We also have something we call an impact investment fund, which is a 25 million euro fund, which is to invest in startup companies that are part of the healthcare ecosystem. And interestingly, many of those have been around supply and pharmacy management, because the last mile delivery and the point of getting cold chain sorted out in many of these countries is still a challenge. So we're looking at how we can do that. So we've got 8 investments now in the last 4 years, and we're looking to continue that to help startups grow and develop to help support patients in the ecosystem. Our overall mission is patient coverage and sustainable patient coverage. So we want to look at how do we prevent diseases, how do we understand how to diagnose them, how do we understand how to manage them, and then ultimately, if there needs to be intervention, how do we make medicines available for treatment. And I've been with Sanofi for 23 years in various roles. I actually ran Africa for 6 years for Sanofi. So before I took this role, I did a global trade job as well. So I have a lot of insight from on the ground of where we see a big gap in low and middle income countries.
Oh, thank you so much. I think already, as part of your introduction, you've already touched on the first question that I had for you. What is happening in the low to mid-income country beyond the philanthropic work, which you've already touched on. So thank you so much for that focus. I don't know if there's any timelines or transparency mechanisms in place to track your progress that you're probably going to be making.
Yeah, so maybe the best way to explain that is explain how we do a project. So the first people we sit down with are generally a Ministry of Health, and we look at their strategy around NCDs, and particularly around diabetes and hypertension. And what are their plans for the future to invest in healthcare? What are their challenges in terms of perhaps not having enough community healthcare workers, not having enough specialists in the cities? And how do we work with NGOs to make a plan, probably over 2 to 3 years, to reach targets that are defined between us on how many healthcare workers we can train, how many more things can we do. We work with people like IDF now, who do online training and accreditation of nurses. That's a big partnership we have. We want to track this from beginning to end, to your point, because in terms of philanthropic work, there's always been a donation, but never really sometimes a follow-up in terms of what we do. So we have KPIs, small team in the office who manage every project, and we look at a targeted number of patients we want to reach, a targeted number of healthcare professionals to train to reach those patients, and we monitor that through the length of the project. Sometimes it goes better than others. It depends on the environment. We're also now trying to find ways that we can help governments collect data so that they can understand what the true issue is in terms of prevalence of diseases. And this is something that, using smart technology, we're trying to use AI now also to be part of how we can monitor that. Because we also want to find the perfect project. Because if we can find the perfect project that's very efficient, then we can transfer that and scale it across other countries. So we are doing monitoring, and we have an impact report that came out at the end of last year, which is our first one. We're due to do another one in the middle of this year, which I'll be happy to share with you, which shows our progress in terms of where we're going. We hope in the next weeks to reach our millionth patient, which is pretty significant in terms of getting patients who are managed. When I talk about a millionth patient, I'm talking about a patient who has been screened, diagnosed, and now is being managed. So you have to meet a lot of people to get to that level. Our ambition is to significantly go beyond this. We're trying to measure that as best we can.
That means a lot, especially for us people living with diabetes. In LMICs, there hasn't been much in terms of data collection. It's always been guesstimate. If you try to check the numbers of people living with diabetes from parts of the world, even if you're going to check on the IDF Atlas, for example, it's usually estimates with benchmarks from countries that do data collection. Because in Zimbabwe, I don't even know how many people live with type 1 diabetes. It's always been basically, we cannot make informed decisions because we don't have the data to back it up. Whatever that is we are trying to advocate for or to speak about, it will be difficult. So thank you for investing in that so that we would know, at least because we know that data is the talk of the moment. You cannot really do much if you don't know how many people are impacted and how many people, you wouldn't even know how much to invest if you don't know how many people need the help that you're trying to put there. So that means a lot to us, and we cannot thank you enough. So as we move forward, I think we could try and speak about meaningful engagement or inclusion and co-creation. We know there's a growing scrutiny on whether people living with NCDs like diabetes, I know Sanofi is not just focusing on diabetes, but NCDs, tokenized thing, or whereby in the shaping of the corporate strategies, what's your model of engagement? And can you share a moment where community input led to a meaningful policy or a market shift? You said you've been with Sanofi for 23 years.
Wow, that's a huge question. I think one of the things that being in a large organization like this is we have a lot of experience in developed markets and emerging markets. Sanofi's always been at it in a big global footprint. And, running Africa, you could see what the learning could be very much from what people have with private insurance and private sector, if you like, care levels, to how do you transfer that into LMICs. The fundamental piece for us for this is education. And back to very basic education of understanding of what diseases are. We've done a lot with faith organisations because there's a lot of faith organisations that are involved in NCDs across the African continent. We've done a lot of trying to transfer knowledge from physicians that are in major centres out to communities. We've looked at working on some of that digitally because a lot of people have smartphones even if they don't have a lot of other things. So we're trying to do that. Policy changes is a really difficult one. But if I go back to my original comment around, we're seeing now more governments are having, particularly the ones we meet in Africa now, are much more waking up and realizing that there is an NCD pandemic out there. And they're realizing that they have to have a strategy that's going to give them the resources to make that happen and make it happen. One of the rules for us is to also, you talked about data, is to explain quite a lot of diabetic patients don't turn up into a major centre until they have a heart attack or they've gone blind or they need a foot removing, or which is pretty horrific, right? How do we explain the cost of that? How do we go back to the very beginning of prevention can work on all of this? So I think we're working very much with the governments on how to think about the patient continuum and starting with prevention. And if you can get prevention right, you can actually manage more people that have the diseases because you're not having the big cost at the end of a major incident. So I think that when we talk strategically about training programs and we talk about implementing a diabetes strategy, we try to use as many of the international guidelines as possible. And one of the things that we notice is that WHO and other organizations have produced pretty significant and very well managed guidelines on how to manage NCDs, particularly diabetes, but they for some reason haven't managed to be rolled out into the communities to understand how to manage diseases. So we try to play a role where we try and encourage that through governments. We try and refer to those, and we try and work with organizations like the WHO, etc. How can we market these guidelines and get them in use more?
Thank you so much. For example, these are some of the things that you're doing at a higher level. So maybe people in the community always been in and out, like what is happening? We don't know what is happening behind the scenes. We may not always be informed, especially when there's engagement with the government. There's usually nothing about us without us. Because we're trying to treat diabetes, prevent maybe complications, like you said. What is that we need to do? I think we need to come up together in the same room, talk of the treatment measures or the things that we need to really do so that the care that gets to us, it's informed by us when we're receiving the treatment. Exactly. So that's why there's been a growing scrutiny.
One of the pieces of all of this is we try to work for the implementation at local level with an NGO that's based in the country or an NGO that has the real expertise in that country. If you look on BBC Storywork, you will see Change for Courage. I can't remember, I'll find the name for you and send it to you, but there's a video we had done in Zimbabwe from a project we've done with community healthcare workers that the BBC have followed. And again, we had to partner with the government, but also a local on-the-ground NGO that had the credibility and the ability to talk to the local people with the right community leaders, the right people, and coordinate what was needed at the local level. And I think this is an example of a project where it got highlighted. It's been something that a short video with it, but we could certainly share more information about that with you. That's the idea of how the model would work. When you talk about everyone getting around the table that needs to be there, that's the point of how it works.
Thank you so much for sharing that. I think, yes, we'll be looking forward to hearing and seeing maybe whatever that was done. So thank you for that, for being honest, also sharing what is happening behind the scenes. We also deserve to know the truth, like what is happening, so that we know we are getting somewhere together. Because it's all about achieving a good quality life for people living with diabetes, which is us. And our governments, they will be happy to see that they're not spending more on trying to treat people who are already on complications. So we always say that prevention is better than cure as we try to get to where we want to get to. Probably there's going to be a cure for diabetes. We don't know that. But
we hope so, right?
Yeah.
The other aims that we want to do is we treat the cardiometabolic patient.
Right.
It's not just about your blood sugar, it's about your hypertension, it's about your cholesterol levels, because if you have one, you generally have two of the metabolic risk factors in a sense. So I think if you're managing that cardiometabolic patient, and when we do the training of the community healthcare workers, we make sure that they look at a patient as a cardiometabolic patient. So we manage what can be a group of life-threatening diseases, which includes diabetes.
Wow, thank you so much. A follow-up question on that. How do you see the role of lived experience community in helping to increase the uptake of the new pharmaceuticals?
It's interesting because I've worked with many patient associations over the years. Yes. Patients should have a voice.
Right.
I think patients should be at the table. It's always difficult, and I think you've said it, we should be listening to how do you live with a disease and what are the pain points we can work with. I think there's definitely a role for patient association.
Wow, thank you so much for that. I think that crystal clear. Thank you for emphasizing on that. It did come out already, but I wanted you to just speak it out. We cannot think enough for that transition to the next stage on accountability at scale, the structural solution that you have on. What do you believe your company's responsibility is in holding governments and global institutions accountable for their part in the NCD care?
I think we're on a journey together in a sense, right?
Yes.
And I think it's not just one company. I think companies have to come together.
Yes, definitely.
And how do we support? And NCDs is an enormous topic. Everything from mental health to childhood care to maternal to asthma to the topic we're talking about here to diabetes. Right. And I think think it's a huge umbrella challenge the industry is very well aware of, and I think we're getting better at looking at how do we come together and try and be more efficient in terms of delivering projects like I'm talking about in terms of education and so on and so on. I think there are still some challenges across with governments in particularly low middle income countries for simple things like registration of products, regulatory process. It is incredibly complex and incredibly slow, and that makes it painful for large organizations. It makes it very costly, and it also prevents innovation for patients who might be eligible for product. So I think there's that. Then I think going back to a little bit what I said at the front, I think we're getting better now to understand, to sit down with governments directly and help them to look at how do they improve the healthcare strategy. I mean, ministers change all the time,
Yes.
parliaments change, but we try to find the right people to work with that are going to be continually delivering the work.
Wow.
And I think that's something we're getting better at. So I think that's something when we talk to governments, they have to be open to allow us to work with the people that are really doing the implementation.
Right.
Politicians move and their strategy changes and so on and so forth. I think one of the things we're doing a lot of is, and this is about data again, is showing that investment in healthcare is an investment in your people and your nation.
Right.
It's not a cost as such. And I think this is something that we all need to try and work on together and think about how do we frame that differently. And I think we have a role to do with that. Mm-hmm. And then we have a role absolutely to ensure that we can get healthcare to as many of the world population as possible in some shape or form. Right. Because in the 40 countries that I cover, many of the countries have very little, large parts of the population have very little access to any healthcare. So that's why we are building the capabilities. It's why we're building the access to learning. And we want to have more people at community level who are able to screen and prevent and then manage diseases if needs be. And I think that's a role we can play hand in hand with major NGOs, major foundations, and governments as well. We need to just be more open to talking together. Wow. You know, it's funny, we go to these large conferences and we sit. I'd like to see more people from the countries there, more people from ministries, and where we can have the dialogue in the room.
But do you think if there wasn't much of governmental change, do you think could have been somewhere?
You know, it's the same in everywhere politicians change. So it still have a strategy that the people have bought into. Right. And then each politician, if it's a good strategy, we need to support delivering it and continuing that delivery.
Great. Many a times you get to see that others are blaming the big pharma, others are blaming the government who is probably failing to put some regulatory measures to make sure that if insulin comes to the country, it's going to be affordable, right, to the people, because they know they are the ones who determine how much should be the disposable income for people, right? Because it's always different in each and every country.
Yeah.
Definitely. The next question that I have for you is on justice over charity that we have. Sanofi has positioned itself around global health for years. How is it shifting from the traditional CSR to a justice-based care model of pharmaceutical equity?
My model is a non-for-profit commercial model. So we sell product, right? And we sell product on a non-for-profit basis. Then the non-for-profit piece, the piece makes a small margin, goes back into the projects that increase the healthcare workers' capabilities. So it's a different model. It's part of a CSR pillar because as a company, we're a purpose-driven company. So we believe that health equity and people should have health coverage. Doesn't matter where you are on the planet. Yeah. So this is a particular model that plugs into that corporate social responsibility platform, if you like.
We always talk about that, yes. Health equity. You should have access to the medication that you need, irregardless of where you're from, right? That should be the thing. So thank you for that. And I don't know, how is Sanofi investing in health systems to strengthen those health systems where you operate?
We work with the classic model of we sit with the government. We support an investment ourselves to get healthcare workers and community workers started. Right. We sign deals with people like the IDF so that they can have programs on distance learning. We will fund local NGOs to implement and deliver projects. And then we look to help support funding afterwards from how does a government reserve funding to take the projects forward after they've been started? And how do maybe other big, large NGOs or big foundations get involved? And that's what we try to do. So when we start something, we're already thinking about, once we've done the capability training and once we've done the training of the community healthcare workers, how is that going to be funded when our project finishes? And how is it going to be continued? Because we want sustainability. You know, there's no point in doing something for 2 years and then stopping and it stops. We've got to make sure that good work continues and the patients get the support that they need, particularly remotely.
Well, thank you so much. I'm just I'm out of words. So thank you so much for answering all these questions. The last question that I have for you is the big question. Try to imagine in your ideal world, because this is something where everything is going to head to if we are to have a cure. I don't know, in our generation or generations to come, people have been always hoping that we do. But maybe in your ideal world, what kind of treatment do you think is the best treatment, meaning the most affordable, accessible, and scalable for all people with type 1 diabetes, not just for them to manage their condition, but also potentially cure the condition?
The treatment is probably the one we haven't discovered yet. Imagine you could find something that is a one shot. I don't mean one injection or one pill, but it's one thing that encompasses everything. That would be the perfect solution.
Wow.
But we're not there.
Thank you for keeping it short. Oh, that is amazing, because it's a big question. It needs a straightforward answer. As we conclude, what would be your last word to the community, especially people living with diabetes who probably have thousands of questions?
I think we're well aware of how we can support communities across low middle income countries. I think when they do see screening programs or being set up in the local community, go and get screened. Go and see your community healthcare worker, because if the government is reaching out or an NGO is reaching out or we're reaching out to try and screen and understand what the prevalence is, or we're trying to manage diseases, we need people to come forward. And there's still a bit of a stigma around, do I have diabetes? Do I have hypertension? Do I have whatever? And we sometimes when we're doing screening programs in countries, we find it difficult to actually get people to come forward, particularly in remote communities. So it's a bit of an urge to people that they get themselves monitored. May well be fine, but we can manage. A lot of these diseases can be managed with lifestyle management. And today, because we're educating more and more healthcare professionals, even if you do have something like diabetes, it can be managed. You can lead a normal life. The patient has to take some accountability and responsibility themselves. And then we have to work on making sure there's enough healthcare workers, enough access to affordable medicine that will treat them when it's needed.
Thank you so much, Jon. Promises are made for the community. Probably you're going to have this in the next years. Maybe it's the agency that pushes you and you're doing the best that you can. Promises are made. And we know that we deserve equity, we deserve transparency, we deserve dignity. Until that is a reality, we cannot think enough and we'll keep asking the hard questions.
Okay.
So thank you for taking the time to be part of this podcast. I hope that our listeners would be thrilled as we continue even to get involved. So thank you.
Good luck with your journey.
Thank you so much. Thank you so much.